Hi, and welcome to Module 2 of Medication Management in Patients with Advanced Illnesses. This is Dr. Diana Stewart. I have with me Dr. Lynn McPherson and Dr. Nikki Brandt. For this section, we will be discussing Pain Assessment and Management, Part 1. By the end of this module, the hope is that you'll be able to describe pain according to the International Association for the Study of Pain definition. That sounds very official. List the 5 steps of pain pathogenesis and define allodynia and hyperalgesia. So let's get some facts about pain. Chronic pain affects approximately 100 million Americans. The incidence is actually higher than the combination of some of our most common chronic disease states that we talked about in Module 1. So this includes diseases like diabetes, coronary heart disease, stroke, and cancer. There are a lot of different conceptions about pain. So some people think that pain is only objective, but this is definitely not true, or that it's only a physical symptom. But we find that there's often an emotional or spiritual type of pain that patients can suffer. Some people believe that pain is a normal part of aging. It's just something that you have to go through at the end of your life. Or pain is something that improves character and builds you up. Also, some people believe that pain should only be treated if severe, but as pharmacists, this is something that we try to provide education on. And pain is really a combination of the awareness of painful stimuli and the emotional impact of that experience. So let's look at this official definition. According to the International Association for the Study of Pain, pain is an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage or described in terms of such damage. So that's a bit of a cumbersome definition, but let's go to the next slide to see something that's a little easier. I really like this slide by Margot McCaffrey, and it says, whatever the experiencing person says it is, existing whenever the experiencing person says it does. So, Dr. McPherson, how do you incorporate this phrase into your practice?
Well, I think what I really stress to my patients is pain is subjective. If they tell me the pain is a 7 on a 0 to 10 scale, I can't draw a blood sample, run it down to the lab and say, you lie like a rug, it's really only a 4. So I have to accept the patient's definition of the pain, how bad they think it is, and where they tell me the pain is.
And I find this is something we often have to educate prescribers on also. A lot of times I'll hear from the medical resident, well, this patient's sitting up in bed, so there's no way they're actually in a 7 out of 10 level of pain. But patients can live at a number of different severities of pain and function the way we wouldn't really anticipate. So let's start out with a question. Which of the following statements about pain is true? Pain is whatever the doctor says it is. Pain is a sensory and emotional experience. Pain is unavoidable in old age. And lastly, pain is not a common condition. Dr. Brandt, what do you think?
We definitely know, I work with older adults, it definitely is avoidable in old age, and it definitely is not whatever the doctor says it is, because oftentimes they're not good at anticipating what someone else's pain is. In my mind, and we know that it's very common based on the statistics you just shared, so by process of elimination and what we just defined, it is truly a sensory and emotional experience, and that's why there's been such a discussion about the connection between pain and mood disorders that I know we're going to talk about a little bit more with depression and anxiety as well.
Well, I know what sensory is. Sensory is the sensation of the pain. What's the emotional part, do you think?
Well, if you live with chronic pain or severe pain, that can really have a huge impact on your life. It can cause isolation from your friends and family and really make you feel upset about the way your life is going. Most people don't walk into a situation thinking, I'm signing up for severe pain for the rest of my life. It can be really distressing for patients.
Sounds like a lot of depression goes with pain.
I agree. So let's see. And it looks like Dr. Brandt is right. Pain is a sensory and emotional experience. So getting into some of the descriptions of pain, and these are things that you'll frequently see documented in a patient's chart. So the intensity, is the pain mild, moderate, or severe? You can also ask the patient to give you a score on a range from 0 to 10, with 0 being no pain and 10 being the absolute worst pain that they can imagine. We typically define mild pain as a score of 0 to 3, moderate pain as a score of 4 to 6, and severe pain as a score of 7 to 10. You can also talk about pain in times of its time course. So is it acute or chronic? And Lynn, when would you typically say that a patient is experiencing chronic pain? What's the cutoff?
Well, the literature defines chronic pain as pain that lasts 3 months or longer, but I like the more user-friendly definition of pain that persists beyond the expected healing process. So I always use the example of a paper cut. I think I'm the only person in the world who needs admission to the intensive care unit when I get a paper cut, but generally that should not be hurting by the next day. So if your paper cut is still hurting 3 days down the road, I think that's starting to look a little chronic.
Sure. And then the next one is baseline or breakthrough. And what do we really mean by this? So when you look at a patient's pain, a lot of patients with severe pain will experience a consistent level that occurs throughout the day. They always have at least a baseline level of 6 out of 10 pain. But then they might have incidents of what we call breakthrough pain that occur on top of their persistent level of pain. And you can stratify these as something that's caused by movement. So if the patient gets out of the bed to go to the bathroom, that could be a cause of pain. Or there could be an unknown reason. These things come on spontaneously, and the patient really can't anticipate when the breakthrough pain will happen. In terms of talking about different types of pain, we break it into 2 large categories. These are nociceptive and neuropathic pain. Nociceptive pain can be further broken down into somatic pain and visceral pain, which we'll discuss in the next few slides. So what does nociceptive pain mean? This is pain that's due to an ongoing activation of nociceptors by tissue injury. And what are nociceptors? Well, these are sensory receptors that are located throughout the body. Visceral pain is a subset, and this is the type of pain that arises from your internal organs, such as if you had stomach cramping. This type of pain is typically diffuse and difficult to pinpoint, so if you ask a patient who has visceral pain to point to where their pain is, they might just gesture to a broader area over their abdomen. They won't be able to exactly put a finger on it. And when you ask patients to describe their pain, some of the phrases you might hear used to describe visceral pain include gnawing and cramping. This is compared to somatic pain, which is due to injury to the musculoskeletal system. And this type of pain tends to be more well localized, so the patient actually could put their finger on it. And the common descriptive phrases patients will use include things like sharp and aching.
Can you give us some examples of those 2 types of pains?
So I like to think of stomach cramps for visceral pain, but other conditions like peritonitis could cause visceral pain from compression of your internal organs. And then somatic pain, a great example would be a cut. So that's something to the skin or the muscle if you work out too hard, maybe at the gym. So those are other common examples of somatic pain.
So let's see if Dr. Brandt's awake here. So if I said my patient's constipated and they're complaining of this colicky type pain, would you say that's visceral or somatic?
I say that's more visceral.
That's right. So
Yeah.
it's involving your guts. And how about if someone said, oh, I've got cancer, and the doctor said it's spread to my bone and my leg bone really, really hurts. Is that visceral or somatic?
That's more of a somatic pain.
Exactly.
Yeah. A lot of common complaints I get regarding somatic pain, especially lower back pain.
Mm-hmm.
Yeah,
Which makes it even more complicated because you have to throw in some nerve pain there too, don't you?
absolutely. And I know you're going to get into that.
I think that's what you call a trifecta.
It is.
Yeah.
So you're right. Next we will talk about neuropathic pain. This is due to damage or dysfunction of your peripheral or central nerves. And this can be due to damage to non-neuronal tissue around the area of the nerves. These lesions can occur at any point along the actual nerve structure. We won't get into too many details about the pathophysiology since it's pretty complex, but a lot of neuropathic pain involves a number of different mechanisms, and this can make neuropathic pain pretty tricky to treat. So, Dr. McPherson, when you're looking at a patient with neuropathic pain, do you think it's going to be easy peasy to get rid of their pain?
No, I think most chronic pain, chronic non-cancer pain, it's very rare that we can make the pain completely a 0. But I think you're on the right track here because assessing the pain and trying to determine the pathogenesis is really the path to helping us determine the best plan of care.
I agree. So next we have neuropathic pain. And Dr. Brand, do you see these conditions commonly in your long-term care facility patients?
Very commonly. We have a lot of patients living with prolonged diabetes, and they may not have been well controlled, though they might be controlled now, but they have a history of not being very well controlled. Of course, with chemotherapy treatments or the sequelae from some of the chemotherapy treatments and shingles. Despite our attempts to give patients our shingles vaccine, we're still, having patients with shingles. And if it's not identified early on, right, in terms of the treatment, that nerve pain is just challenging. And nerve compression, as we talked about, whether it's because of a history of lower back injuries or we see with frailty increasing vertebral compression fractures, leading to that nerve compression. So really tough pain to manage, and look forward to the discussion on finding that balance with pain management here.
Absolutely. So why do we need to go through pain? Why does the body hurt? Pain is a response to damaging or potentially damaging stimuli, and the translation of damage into pain is an adaptive response. So if you put your hand down on a hot stove, that's your body's way of protecting your hand from getting permanently injured. So as soon as you put your hand down, your instinct is to pull back and avoid that pain. And they've actually shown that having the presence of pain provides a reproductive and survival benefit to living creatures. So it's not something that we enjoy, but it is a necessary part of survival. So getting into the pathophysiology, like we mentioned, nociceptors are the sensory receptors located throughout the body. And you have these all throughout, including your skin, within your internal organs, the muscle, joints, and tendons. And it responds to a number of different stimuli. So it isn't just things like cuts and burns. It'll also respond to chemical damage and proprioceptive damage. So Dr. McPherson, what does proprioceptive damage mean?
I think what you're looking at,
It's from movement, right?
I
So
was not quite sure where you were going with that one.
that's a phrase a lot of people aren't really familiar with, but that's pain that you can feel from movement. So if you overextend your arm, we would refer to that as proprioceptive pain. Didn't mean to stump you there.
You did stump the jump with that one.
So looking at the pain pathway, these signals travel along a complex neuronal network via what we call afferent neurons. And we have two main types of fibers. These are A delta fibers and C fibers. So you could throw these phrases out at a dinner party and it'll make you sound pretty smart. The stimulus in the periphery or outside of the body then becomes interpreted centrally within the brain. So 5 main steps. This is pretty easy to remember. It's only 5 steps for a pretty complex process. We start out with transduction, then conduction, transmission, modulation, and lastly perception. So let's talk a little bit about what each of these steps mean. Transduction is when the noxious stimuli is translated into a nociceptive impulse. It's first carried by those A delta fibers, which are fast fibers, and then carried by slow C fibers. So I think this marathon runner looks like he's probably more of the A delta fiber type. He looks pretty fast to me. Then what does conduction mean? So this is when that nociceptive impulse or the painful stimuli travels along the peripheral nerves and is communicated between nerve cells. So Dr. McPherson likes to use this phrase a lot called passing the baton. So that's when the nociceptive impulse jumps from one nerve to the next. The next step is transmission. So that nociceptive signal travels up to the dorsal horn in the spinal cord and is then sent to the thalamus. And that's really like a relay center within the brain that processes this information. And there are different parts of the brain that are responsible for interpreting different types of pain. So a different area might interpret sensory aspects of pain, such as quality and intensity, but there are other parts of the brain that become activated and are really responsible for that emotional response to pain. So modulation, how do you modulate pain and what does this really mean? Modulation is an increase or decrease in the magnitude of a pain signal. So this really means that you're getting an alteration between the painful stimulus itself and the final sensory experience of pain that the patient is experiencing. And this involves a lot of different substances such as neurotransmitters within the body. Lastly, we have perception. This is the patient's subjective experience of the pain. And all of this results from that pathway of nociceptive signaling and the psychological aspects of the patient. So this is really how does the patient process and interpret their pain. And this can be influenced by a number of different things, such as age, the patient's gender, their already present level of stress, and their memories of previous painful experiences. So here's a fun vocab word. Dr. McPherson, how would you describe allodynia to somebody?
Allodynia is pain from a non-painful stimulus. So if I took one of these fancy feathers here and ran it down your arm, in a normal person it would tickle, but if you said ouch, that would be an example of pain from a non-painful stimulus. And this term is allodynia, and it absolutely represents neuropathic pain.
Great. Our other fancy word is hyperalgesia. So Dr. Brandt, how would you describe hyperalgesia to a patient?
So this could be, and I see you've got these little tacks there. So when we're doing, for instance, a neurologic exam and we might just touch that sharp object to the bottom of their foot, they pull back real quickly. So it's an amplification of that painful response. So it might just be a little bit of a touch, but it's enough to really cause them to be staggering in pain. So, and we, that's one of the reasons we're doing foot exams in diabetics, right? So yeah, that's how I describe it. I've witnessed it too.
Great. And hyperalgesia is another hallmark of neuropathic pain. These are not fun things to have. All right, so let's take a break with a question. Take a minute to go through and list the 5 steps of pain signaling. So here's a $1 million question. Dr. McPherson, can you list them?
Wow, those are a lot of words there. So transduction, I know what that is, and conduction is moving it along the A delta and the C fiber. Transmission is passing that baton. Modulation is trying to reduce the pain message, and perception is recognizing that it is pain. So I'm liking A, but let's look at B. Well, the first 4 words look familiar, but perspective, well, I understand what perspective is. I don't think that's one of the words we use in talking about pain. And in C, confirmation, I don't think that's one either. So I'm going to have to go with A.
Let's see if you're right. And it looks like you are. So answer A. These are the 5 steps of the pain signaling process.
Do I get a cookie?
Maybe at the end.
Maybe at the end, okay.
Stick with us.
And it looks like you do get that cookie. So this concludes part 1 of Module 2, Pain Assessment and Management. We'll see you in part 2.